Welcome to The Explainer. Today, we're zooming in on one of the most fascinating and downright powerful medications in our entire clinical arsenal. We are talking about vancomycin. Now, you know as well as I do, this isn't your everyday, run-of-the-mill prescription. This is what we call the heavy artillery.
So what happens when standard antibiotics fail? Picture this. You've got a highly resistant superbug. Standard frontline defenses like penicillins or cephalosporins, they're just not cutting it. We can't just surrender, right? Instead, we call in the big guns. Vancomycin is a true last line of defense for some of the most stubborn, aggressive pathogens known to modern medicine.
Okay, here's our roadmap for today's deep dive. We'll start with 1. Meet the heavy artillery. Move to 2. Targets, MRSA and C. diff. Cover 3. Mechanics of administration. Discuss 4. Beware the red man. Navigate 5. Walking the tightrope. And finish up with 6. Essential takeaways.
Let's dive right in with Section 1. Meet the heavy artillery, the glycopeptide profile.
So vancomycin is a glycopeptide antibiotic, but what does that actually mean for us? Let's break down this incredibly complex mechanism. We know bacteria rely on a tough cell wall to survive, and they build it using something called peptidoglycan. Well, vancomycin goes right for the structural integrity of that wall. It binds directly to a very specific target, the D-ala-D-ala terminus of the cell wall precursors. Imagine this terminus as the absolutely crucial mortar holding all the bacterial bricks together. By latching onto it, vancomycin completely halts peptidoglycan synthesis, and the result, the bacterial cell wall literally shatters. This doesn't just slow the bacteria down, it destroys them. It's a profoundly bactericidal effect. Moving right along to Section 2. Targets, MRSA and C. diff. Now that we know how it shatters cell walls, who exactly are we targeting? Vancomycin has a highly specific hit list. It is famous, literally famous, for taking down methicillin-resistant Staphylococcus aureus, or MRSA. It also targets MRSE and those really tough enterococci. But here's the crucial point you've got to remember. It possesses absolutely 0 gram-negative activity. None. 0. It is a gram-positive specialist through and through. Beyond active infections, we also use it very strategically. It's our go-to for surgical prophylaxis if a patient has a severe beta-lactam allergy, meaning they absolutely can't take penicillins or cephalosporins. Plus, it's used as empiric therapy for patients with febrile neutropenia when a severe MRSA infection is suspected, but we just don't have those culture results back yet. Look, we're not pulling this drug out for a mild scrape. We're talking about high-stakes, severe systemic infections. We're looking at bacteremia, which is a blood infection, endocarditis, where the heart valves are actively under attack, osteomyelitis, which is a deep-seated bone infection, and severe resistant pneumonia. These are literally life-threatening scenarios where failure is simply not an option.
Next up is Section 3. Mechanics of administration, IV versus oral.
So a drug this powerful needs strict rules of engagement, and vancomycin actually leads a bit of a dual life depending on how it's administered. For systemic issues like those blood or bone infections we just talked about, it absolutely must be given intravenously. From there, it travels through the bloodstream and is eventually excreted by the kidneys. But what about oral administration? Well, you will only ever see it given orally for one specific condition, Clostridioides difficile or C. diff colitis. Why? Because it's incredibly poorly absorbed in the gastrointestinal tract. Clinical pharmacology actually uses this limitation brilliantly as a weapon. By giving it orally, the drug doesn't enter the bloodstream at all. It just stays trapped in the gut, which is exactly where the C. diff bacteria are wreaking havoc, delivering a massive localized strike.
Which brings us to Section 4. Beware the red man, managing infusion reactions.
Now we have to talk about the friendly fire associated with mishandling this medication. There's a very precise sequence of events here. Step 1 is a rapid IV infusion of vancomycin. Pushing this drug way too fast triggers Step 2, which is a massive, sudden release of histamine in the patient's body. This massive histamine dump leads straight to Step 3, severe flushing of the face, neck, and torso, a red rash, intense pruritus, which is severe itching, and a really dangerous drop in blood pressure, known as hypotension. This entire chaotic cascade is historically known as red man syndrome. So how do we stop it? Well, prevention is entirely in our hands. You simply ensure a slow infusion, typically over 1 to 2 hours. Listen up, because this is a massive myth-busting fact. Red man syndrome is not an allergy. slow the infusion. I can't emphasize this enough. If a patient starts flushing red during a vancomycin infusion, your instinct might scream, "Oh no, anaphylaxis, true allergy." But actually, scratch that. It's not. It is a rate-dependent infusion reaction. So the immediate action isn't necessarily to ban the drug from their chart forever. It's to stop or slow the infusion down, maybe pre-medicate with an antihistamine, and just manage that rate. Let's move over to Section 5, walking the therapeutic tightrope, narrow therapeutic index. You're going to want to anchor this number in your mind, 10 to 20 micrograms per milliliter. Vancomycin has what we call a narrow therapeutic window. That means the difference between a dose that cures and a dose that causes serious toxic harm is incredibly, dangerously small. It's a clinical tightrope. Because of this, we have to pull blood and constantly measure the drug levels. This 10 to 20 range is the target for the trough level. The trough is simply the lowest concentration of the drug in the patient's bloodstream, and it absolutely must be drawn just before the next scheduled dose is given. Think about it. If it's too low, the superbugs survive and multiply. If it's too high, we risk severe toxicity. And here's another vital number for you, less than or equal to 10 milligrams per minute. This is the maximum recommended IV infusion rate. Connecting this back to what we learned a few moments ago, strictly adhering to this maximum rate is exactly how you prevent red man syndrome. It ensures the drug enters the system gradually, keeping those volatile histamine cells nice and calm. So, once it's doing its job in the system, how does it get out? Well, vancomycin is excreted primarily by the kidneys. This means renal clearance is absolutely paramount. If a patient has impaired kidney function, the drug literally can't escape the body. It backs up, the serum levels skyrocket, and the patient is suddenly at a significantly higher risk for toxicity. That is exactly why dose adjustments based on renal function labs are totally non-negotiable. Finally, let's wrap up with Section 6, Essential Nursing Takeaways, Monitoring and Safety. When we're monitoring vancomycin, there are two massive dual threats we've got to watch for. First up is nephrotoxicity, which is kidney damage. You're going to spot this by keeping a close eye on elevated BON and creatinine labs and watching for any decrease in urine output. You monitor this proactively with daily weights and strict input and output tracking. The second big threat is ototoxicity, which is damage to the ear and hearing. The telltale signs here are hearing loss, tinnitus, which is that annoying ringing in the ears, and dizziness or vertigo. For patients on prolonged therapy, getting a baseline hearing test is incredibly important so you actually have something to compare against down the line. Since we are the ultimate clinical safeguard here, we have to empower our patients to spot danger early too. They must be taught to immediately report any ringing in the ears, any dizziness, or a noticeable drop in how much they're urinating. Those are our huge red flags for ototoxicity and nephrotoxicity. Furthermore, always remind them to complete the full course of therapy to fully eradicate the bug. And on a larger systemic healthcare level, we must reserve vancomycin only for resistant infections to prevent the creation of vancomycin-resistant enterococci, or VRE. We absolutely have to protect our heavy artillery so it actually works when we truly need it. So having walked through exactly how it shatters cell walls, its highly precise targeting, and the intense, strict monitoring it demands, it leaves us with one final thought. As the ultimate clinical safeguard, are you prepared to handle the heavy artillery? Administering these last resort medications carries immense responsibility for sure, but armed with this knowledge, we can ensure both safety and efficacy. Keep exploring, keep questioning, and I'll see you in the next explainer.